Good morning, everyone. I appreciate you all being here. I'm looking forward to share my progress for over the past 1 year. Title of my PhD work is Evidence-Based Solutions for Orthodontic Acceleration. My name is Nazanin Ghods. I'm a dentist and first-year PhD student, originally from Iran. My supervisors are Gabor Varga and Tibor Zelish, and I would like to transform orthodontics with effective non-surgical solutions by delivering evidence-based solution for orthodontic acceleration. I have two ongoing projects. First one started on September 2024, and the second one on November 2024. Title of my first project is Investigating the Safety and Efficacy of Non-Invasive Accelerated Orthodontic Techniques in Adult and Adolescent Orthodontic Patients. More than 5.75 million patients per year only in US and Canada need orthodontic treatment. This treatment lasts 18 to 36 months with pain and complications. As a result, 1 out of 4 patients decide to discontinue their treatment. This leads us to accelerated orthodontic methods, which they can be light-based therapies, they can be electromagnetic field therapies, electrical stimulation, or mechanical and sound wave therapies, such as vibration and ultrasound. These techniques work in a way that when mechanical stimulation increases, there will be increase in the blood flow, and as a result, healing is going to be stimulated. That's why our aim here is to identify patient-friendly, effective, non-invasive adjuvant treatment therapies that minimize treatment time and risk. Clinical question here is, do accelerating methods combined with fixed conventional orthodontic treatment shorten treatment time and reduce post-activation pain? And we're hypothesizing that use of these techniques alongside fixed conventional orthodontic treatment lead to faster tooth movement and shorter treatment time and post-activation pain reduction. For this project, we're using PICO framework with population of adult and adolescent orthodontic patients. Our interventions are the techniques we discussed earlier, and our comparator is fixed conventional orthodontic treatment. We have two sets of outcomes. The primary outcome is rate of tooth movement, and the secondary, as you can see below, with clinical implications of guideline update and increased patient satisfaction. We constructed our search key in 3 domains. Our second domain is summary of all the interventions we're investigating, and on the third domain, we're making sure we're covering only trial articles. We conducted the search key in 3 domains, in 3 databases of PubMed, Embase, and Cochrane Library in 14th of November. First, we started our search with 3,518 articles, and after our selection process, we found 83 articles. We also did the citation chasing, which we found 36 new articles meeting our inclusion criteria. There are several finished analyses and several ongoing analyses, such as rate of canine retraction and pain. This forest plot is post-initial arch wire placement pain. Initial arch wire placement is one of the main stages in orthodontic treatment. Pain also plays a crucial role in every treatment, especially true in orthodontics. When the pain level is too high, it affects patient satisfaction, cooperation, and the result of our treatment. Unit of pain measurement here is visual analog scale and numeric rating scale, ranging from 0 to 10 here. We used 5 studies in order for this forest plot. However, only 3 of them came into calculation. We had 2 groups of laser and placebo, with total population of 186. Our heterogeneity level is 0%. However, it doesn't mean that we have low heterogeneity, but rather that we needed more articles in order to measure our heterogeneity according to. If we checked our pooled mean difference and pooled confidence interval, both being below 0, it suggests that use of laser in order to reducing post-initial arch wire placement pain is clinically and statistically significant. Mass retraction at different follow-up times is title of this figure. Mass retractions means how fast we can move 6 anterior teeth from canine to canine backward in order to close the space. Unit of measurement here is millimeter, ranging from 0 to 11 millimeter in this figure, measured in 10 months. The higher of a slope we have here, the faster tooth movement and space closure we have. And the interventions we're investigating are electrical stimulation, laser therapy, LED, and vibration. We used 7 studies and 53 estimate points in order to create this figure. If we check the numbers by detail, in the laser group, we had 0.87 millimeter per month. In electrical stimulation group, we had 0.37 millimeter per month. This suggests that laser and LED seems positive effect. In vibration therapy, we had moderate effect, and in electrical stimulation, we had 0 to low effect in making the tooth movement faster. However, if we check the confidence interval solely for the laser group and compare it to the vibration group, it suggests that use of laser in making the tooth movement faster in the mass retraction stage is clinically and statistically significant. At this stage, we're done with risk of bias assessment. However, we're waiting for more and more figures and tables from our statistical team. And only after that, we're allowed to move to grade analysis and writing the rest of our manuscript. My second project is investigating the accuracy of semi and fully automated cephalometric analysis in orthodontic patients. More than 5.75 million patients per year, only in US and Canada, need orthodontic treatment and cephalometric analysis. Cephalogram is a radiograph of sagittal plane of head, which helps us with analysis of dental and skeletal relationship. There are several landmarks that are joined together to form planes and angles. This analysis can be done in 3 possible ways: manual, semi-automated, or fully automated. Now imagine you're an orthodontist with 200 new patients per year. You have 2 possible options to do this analysis, either fully automated or manual. If you choose the fully automated, this analysis takes only 30 seconds, but if you choose the manual, it takes 30 minutes. So, if you choose the fully automated, then you will save 100 hours in 1 year and 30% less error rate. By error, I mean variability, landmark identification, and landmark detection. So, these errors will lead to inaccurate diagnosis and treatment plan. That's why our aim is to investigate fully automated cephalometric analysis for its landmark detection accuracy and speed. Clinical questions here is, does fully automated cephalometric analysis provide similar or better measurement consistency and workflow metrics than semi-automated and manual method? And we're hypothesizing that use of fully automated cephalometric analysis does provide better or similar measurement consistency and workflow metrics. For this project also, we're using PICO framework with population of orthodontic patients that need cephalometric analysis. We have 2 sets of intervention, fully automated and semi-automated cephalometric analysis. And our comparator is gold standard, which is manual cephalometric analysis. We have several sets of outcomes such as angular and linear measurements and the rest, with clinical implications of increasing accuracy and guideline updates. As an example, I can show you the set of key articles for the manual cephalometric analysis. I color-coded the outcomes based on the primary and the secondary, and the article that I highlighted is the article that simply compares manual with semi-automated and fully automated cephalometric analysis. For the summary, my first project is expected to end in October 2025, and the second one in November 2026. And at the end, as I conclude, I would like to leave you with a quote from the Persian poet Saadi Shirazi: "Have patience, all things are difficult before they become easy." Thank you for your attention.
Thank you very much. Very nice presentation. Questions from the audience?
Congrats for your very well-structured presentation and your speech. So I was curious about, have you come across any other AI applications in orthodontics? And if yes, what are your thoughts regarding that?
For the AI?
Yes, yes.
So the hot debate these days is like if they can make an AI system or like AI network algorithm that can make the treatment plan and predicting of how the tooth movement and the orthodontic procedure is going on. But that's a very new topic. So I was very much interested in that, but unfortunately there's not many AI in making the treatment plan, or the only AI system that they're introducing, but it's not like fully, like it's still in the research, it's not fully established, is like they created an AI system that can predict which tooth we can extract and which tooth is needed to extract. But so far, that's only the stage for cephalometric analysis and extraction. But the extraction is under the debate,
So just a, like early stage. Yeah. Okay, thank you very much. Thank you.
Okay.
Thank you. Congrats for your presentation. I'm just wondering, what was the reason that you have applied manual calculation in your first forest plot?
So technically, most orthodontists these days, they do semi-automated. But still, as manual is the gold standard, we had to include manual because that's the gold standard of the cephalometric analysis, even though it's not mainly used, but we're just comparing to the manual one.
Nobody else. May I have a question regarding your result? You mentioned pain on day 3.
Mm-hmm.
Can you explain why day 3 is more important than day 1st?
Sure. So we have actually 2 different pain analyses. One of them is like the finished analysis, forest plot that I have for the pain in the day 3. But there's also one ongoing analysis of pain, and that's more vast. Because the pain 3, I had laser and placebo, so I technically had enough data to compare laser with the placebo group. But the other pain analysis that's going on, it's between different interventions and the control group. So statistician team are making that, and that's time-based regression analysis. So it's more complicated than this.
It's absolutely logical right now. So maybe next time you can demonstrate it that it takes time that the low laser therapy make any effect. So that makes sense. Another question, if you have this table, that why some of the studies has no standard deviation? It's a mistake of the plotting, or really there is no standard deviation?
So they were in the line graph technically, but they only provide the mean number. They didn't have it in the numbers in the table to write the standard deviation and the mean number. So they only had one number. But because the result showed that they reduced the pain, so I just included them. But because we didn't have the standard deviation, we couldn't calculate the numbers based on them.
So they are they included in the statistical analysis as well, or just plot?
So they are included, but the pooled mean difference and confidence interval level, it's not in the they're not in the measurement. But they're just a proof that laser did provide positive effect in pain reduction on them too.